Hello and welcome. Today I'll be speaking about a topic called systemic lupus erythematosus. It's a long name, and so for short we'll call it either lupus or SLE. So either of these terms will be used. So when you hear the word systemic lupus erythematosus, what should come to your mind is that first word, systemic. But I'm going to talk about this under this outline: introduction, pathology, risk factors, signs and symptoms, investigations, how to make a diagnosis, treatment, prognosis, and patient education. So when you hear the word systemic, firstly, realize that the body is made up of a large number of cells. These cells organize to form tissue, they form organs, and then they form systems. So when you hear the word systemic, it means that this is a condition that can affect multiple organs, from the skin to the joints to the kidneys, the blood cells, and the nervous system. Sometimes you also hear the description of it as a connective tissue disease or an autoimmune disease. I'll say something about that subsequently. It's a condition that is characterized by antibodies directed against nuclear and cytoplasmic antigens. When you hear the word nuclear and cytoplasmic, what does that mean? In biology, remember that you have a cell, has a nucleus, and then around the nucleus is the cytoplasm. For some reason, if for some reason the nucleus or the cytoplasm becomes exposed to other cells, there could be a reaction. I'll say something about that in a moment. This is a condition that affects more women than men. The ratio of female to male of 9:1. That means about 90% of patients that have systemic lupus erythematosus or lupus are females. It also frequently occurs or starts out at the time of childbearing. This therefore means that there could be some degree of hormonal aspects to this condition. So in terms of the pathology of this condition, the basis is that of a condition that is described as an autoimmune problem. And so what does that really mean? I've made a video concerning rheumatoid arthritis where I explained autoimmunity, so we'll put a link out there. But simply put, you have a situation where you have, say, siblings that have grown up together, they tolerate one another over the years, they don't fight each other because they're siblings, they know each other. But for some reasons, if there is an immune dysfunction, because initially they've stayed in a state of immune tolerance, if there's an immune dysfunction, the cells of the same person begin to fight other cells of the same person. In other words, the body is targeting itself. That is self-destruction. That's the basis of autoimmunity. And so in these patients, there could be what is referred to as accelerated apoptosis. In apoptosis, it's described as programmed cell death. So just the same way humans die, cells die. And so if for any reason there is an acceleration in this process, what that means is that you have a quickly occurring death of circulating lymphocytes. Lymphocytes are a type of white cells. And so if there's also impaired clearance or removal of these apoptotic bodies, it therefore means that you have an increase in the amount of nuclear antigens that are being presented to T lymphocytes. Now, I'll break that down. I said again, once more, you have a cell that has a cell membrane, there's a nucleus, and then there's a cytoplasm. Now, observe that the nucleus is surrounded by a cell membrane, and so it is protected, as it were. When the cell becomes damaged, destroyed, or dies, that nuclear material becomes exposed to other cells in the body. Now, if that is occurring at an accelerated rate, you have a situation where cells of the same person are now reading this nuclear antigen as something that is foreign. In other words, we don't know you. And so they begin to fight. As they commence that fight, they produce what is referred to as autoantibodies. That is the basis of autoimmunity. By producing these autoantibodies, there's also the formation of immune complexes that are not adequately cleared away. And so they set the stage for chronic inflammatory state to occur. And so patients develop different protein manifestations from the head down as far as the toe, as you would see in the symptoms of this condition. Who are those at risk? We talk about genetic factors, hormonal factors, environmental factors. Who are those at risk? Those that have a family history. A number of times you will find a mother with lupus, and then the daughter may also have lupus, or a sibling and the sister, or a situation where somebody in the family has another autoimmune condition, say rheumatoid arthritis, and then somebody else has lupus. If you have a patient that has had recurrent pregnancy losses and they are unable to identify the reason for the recurrent pregnancy losses, it's important to identify or screen this patient for a condition called antiphospholipid syndrome. I've done a video about that and will leave a link for you to also watch. That condition may occur in patients that have systemic lupus. So it may be an indication that we need to look closely at the possibility of this patient also having lupus. For some patients, in situations where you have recurrent malaria diagnosis, it may actually be that the malaria is being misdiagnosed. Meanwhile, there is an underlying condition like lupus. Medications, if you have been exposed to medications such as hydralazine, which we use for blood pressure control, isoniazid for treatment of tuberculosis, prokinamide, if you have been exposed to these medications, tumor necrosis factor inhibitors, you may be predisposed to lupus. Other potential triggers could include infections, silica dust exposure, cigarette smoking, photosensitivity, particularly UV light. Now, UV light causes or stimulates cells of the skin called keratinocytes, which in turn produce cytokines, and these may stimulate the production of autoantibodies. What are the signs, symptoms, or clinical features of lupus? If you have a patient presenting with fever, joint pains, and a rash in a woman of childbearing age, this may be an indication for screening for lupus. Fever, joint pain, and a rash in a woman of reproductive age. If you're a patient that has been receiving treatment for malaria, typhoid again and again, you may actually be somebody that should be screened for lupus. And then you may also want to look at the nails of these patients. They may have what is referred to as melanonychia. I have a video about that. We'll put that also in the link. Melanonychia is a black or brown pigmentation of the nail. This may actually be seen, in my experience, as a bluish discoloration. I had a patient some years ago that presented with features that were not very distinct, but by looking at her nails, it raised the suspicion that this could be lupus. So melanonychia can be a presentation in lupus. Now, please, that's not the only condition that can cause melanonychia. They may also have what is referred to as constitutional symptoms. These could include fatigue. One of the major complaints that patients with lupus may have is fatigue. They feel unduly tired. And some of them, the reason why they may have fatigue is that they have a secondary problem called fibromyalgia. I've also had done a video on that. We'll put it in the link as well. They may present with fever, arthralgia. Arthralgia simply means joint pain without swelling. They may also present with frank arthritis, which is joint pain with swelling. I have a video about that. We'll also put it in the link. They may also present with poor appetite and weight loss. They may have musculoskeletal symptoms, like I mentioned, joint pain and swelling. They may also have myalgia, which is muscle pain, and avascular necrosis. Avascular necrosis simply means death of the bone tissue on account of lack of blood supply. And the joint that is particularly involved is the hip joint, or the head of the hip joint, the head of the thigh bone. They may have skin manifestations, the malar rash, where you have patient presenting with involvement of the skin around there, like looks like a butterfly, the wings of a butterfly, and it's also called the butterfly rash. They may also have photosensitivity. They get into the sun, they tell you that the skin burns, or they develop some skin rash. Discoid lupus. Now think about discoid lupus or discoid as some like a disc, like a, if you remember from the Olympics, people that are involved in that sport, they throw that circular object. So the discoid lupus looks like something that is, of course, not uniformly discoid, but gives you the appearance that something that is somewhat circular and then presenting with skin involvement in that area. They may also have hair loss, and this is really very important. As a woman, typically you will have some degree of hair loss, but it becomes excessive. know that something could be amiss. They may also have involvement of the kidneys, where they tell you that they wake up in the morning, there is some swelling around the eyes, on both sides, or the face looks swollen in the morning, and as the day progresses, it becomes better. They may also have leg swelling. They may also observe that when they pass urine, it foams excessively. The reason why that happens is because there is excess amount of protein in urine, and that is referred to as frothy urine or proteinuria. They may also have blood in the urine called hematuria. Sometimes the bleeding in the urine or the blood in the urine may actually be microscopic. In other words, you can't see it with the naked eyes, but when it's put under a microscope, they will find red cells in the urine. It may also involve the brain, the spinal cord. Now, that is why we talk about this condition as being systemic. It can affect various organs. For the brain, patients may present with seizures, psychosis, headache, migraine, poor concentration, confusion, or even meningitis. In meningitis, the patient has fever, headache, and neck stiffness. And so patients may have what is referred to as neuropsychiatric lupus. In neuropsychiatric lupus, the patient presents as though he or she has a psychiatric problem. And so if care is not taken, the patient may be taken to see a psychiatric doctor. Meanwhile, it's a rheumatologist and other specialties that should look after the patient. Gastrointestinal tract may present with nausea, abdominal pain. The cardiac may present with what's referred to as pericarditis. Around the heart, there is a membrane called the pericardium. If the pericardium becomes inflamed, that is referred to as pericarditis. And if the amount of fluid there becomes so much, it may result in pericardial effusion. And they may also have myocarditis. Myocardium is the intrinsic muscle of the heart. If that myocardium or the intrinsic muscle of the heart also becomes inflamed, that is referred to as myocarditis. Hematologic, the blood cells may also be involved. The three main blood cells, the red blood cells, the white blood cells, and the platelets may all be affected by lupus. Where there is a reduction in the red blood cells, we refer to that as anemia, and that contributes to the tiredness, the fatigue that they experience. Number two, the white cells may also be reduced, that is referred to as leukopenia, and the platelets may also be reduced, that's referred to as thrombocytopenia. So when you have these penias, in other words, reduced levels of these three cell lines, we refer to that as pancytopenia. What are the investigations and why do we carry out these investigations? Firstly, to make a diagnosis. Secondly, to have a baseline before commencement of treatment. And thirdly, to guide the treatment that we're going to be carrying out. And so what are the investigations? Number one, the full blood count. I've just told us about the pancytopenia. So these three cell lines may be reduced, but not always so. The kidney function test to help us to identify whether the kidneys have been involved. Urine microscopy. The urine microscopy will help us to identify whether there's protein in urine or whether there's blood in the urine. And also, the inflammatory markers, ESR, erythrocyte sedimentation rate, CRP, C-reactive protein may also be carried out to determine whether there's ongoing inflammation. The complement levels, the liver function, the creatinine kinase. Creatinine kinase is essentially for patients that have the muscles involved. If there is muscle pain, whether it's myalgia or muscle weakness, whether it's myositis, that may also present in a patient that has lupus. I'm going to put a video link for inflammatory myositis, another video I've done. You may also be required to do a protein creatinine ratio. This helps to really estimate what's going on or to identify the problem with the kidneys. And then autoantibody tests. These autoantibody tests are very important, like I've mentioned, the basis for the autoimmunity or the self-destruction of self that I've earlier mentioned. Imaging studies that may be done may be required to do X-ray or ultrasound for a patient that presents with joint pain, specifically affecting the small joints of the hands. There may be swelling, may not be very obvious clinically, and so X-rays, particularly ultrasound scan, may be important in helping to assess this. Chest radiograph, chest X-ray may be important because the lungs may be involved. Sometimes CT scan may be required. Echocardiography because of the pericarditis or the pericardial effusion. Brain MRI because of the involvement of the brain, where there's what's referred to as lupus cerebritis. Cardiac MRI may also be required. And then some procedures may be carried out, including arthrocentesis. Arthrocentesis simply means taking out the fluid from the joint. Say a patient presents with a big joint, say the knee, with swelling. That may be an opportunity for the doctor to put in a needle, take out some fluid for analysis. Sometimes the patient presents with aseptic meningitis. Remember I said meningitis has to do with fever, headache, neck pain. You may be required to do a lumbar puncture to take out some of the fluid from the brain of the spinal cord to assess. And then sometimes the kidney doctors may do a kidney biopsy. So how does the doctor make the diagnosis? It's going to be a combination of the clinical presentation, the signs and symptoms that I've mentioned earlier on, and the laboratory findings. If these meet up to a particular point, you could say, based on these that this patient has lupus. And the very important serological markers will be anti-nuclear antibody. Now, anti-nuclear antibody is not a specific test for lupus, but it's a sensitive test. What that simply means is that there are other conditions that may have a positive anti-nuclear antibody, but doesn't mean that every person that has anti-nuclear antibody does have lupus. However, in patients that have lupus, they're more likely, most patients will have anti-nuclear antibodies. But a specific test that will be serological markers that will be indicative of lupus will be double-stranded DNA and anti-Smith antibodies, not anti-smooth, anti-Smith antibodies. So you see it's written as anti-SM. It's not smooth, it's Smith. How do we treat patients that have lupus? I would like to divide this into symptomatic treatment and definitive treatment. So for symptomatic treatment, you want to give corticosteroids. Corticosteroids are very, very important treatment modalities that are used, but there's basically to help reduce inflammation, reduce the pain, get things, quickly stabilized, but you will require other medications. So for the corticosteroids, the plan is to use the smallest dose for the shortest possible time. The smallest dose for the shortest possible time, because we know that there are a lot of side effects arising from steroids, but they are very, very potent medications that help to get disease under control. Number two, may require non-steroidal anti-inflammatory drugs such as ibuprofen, naproxen, diclofenac, if indicated, to reduce pain as well. So for the definitive management, we require potent medications that are referred to as disease-modifying anti-rheumatic drugs. These disease-modifying anti-rheumatic drugs may also be classified under conventional disease-modifying anti-rheumatic drugs and biologic disease-modifying anti-rheumatic drugs. For the conventional ones, we talk about anti-malarials like hydroxychloroquine, other medications like methotrexate, cyclophosphamide, azathioprine, mycophenolate, mofetil. So these are medications that will be used. And then for the biologics, we're talking about medications like rituximab, belimumab. These medications are quite potent and they do work. So what's the prognosis if you've heard or somebody has been diagnosed with lupus? The prognosis will be dependent on how quickly the diagnosis was made, how quickly treatment was commenced, and the severity of the condition. For patients that already have end organ damage, like the kidneys or the brain, prognosis may not be as good as patients that are diagnosed early and treatment is commenced early. And it's important to mention that the areas that we're particular about that could result in mortality will be involvement of the brain for patients that have, say, stroke, involvement of the heart, patients that have, say, myocardial infarction, patients that have lupus nephritis, that is not involvement of the kidneys, and infections. So these are areas that can potentially determine the prognosis of the condition. Now, what should a patient do when diagnosed with lupus? 10 tips. Number one, learn as much as possible about this condition. And when I say learn, I don't mean just go to any site on the internet. Look at reputable sources. And this video is one video I think you should watch again and again to learn. And if you have questions, you could put them in the comment section. And if you have certain other aspects that you want me to make videos on, I'll be happy to take a look at what you're requesting. So learn about this condition. Number two, realize that this condition requires a multidisciplinary approach in the management. In most cases, the rheumatologist will take the lead, but of course it depends on the area that is involved. If it's mostly a skin involvement, it's a dermatologist that will be focused on that. Sometimes you have what is called cutaneous lupus or just discoid lupus. But if it's systemic lupus, it's most likely the rheumatologist. If it's the kidney that is primarily involved, it will be the renal physician or the nephrologist. So it depends on what is really involved, but it will require a multidisciplinary approach. Number 3, it's important that you adhere to medications and follow-up appointments. Now, when it comes to medications, I'm sure you've heard me mention some very strong medications, as it were, methotrexate, and you're wondering, isn't this used for cancer treatment? Well, I need to mention to you that some medications can have multi-purpose use. And the fact that a medication is used for some other condition doesn't mean that it cannot be used for this condition. Number 2, in terms of using medications or application of medication, it's important that what a doctor does is to look at the benefits versus the risk. If the benefit of treating outweighs the risk, then that discussion needs to occur between you and the doctor to look at starting the medication. And remember, when you are placed on this medication, you're going to be monitored. Nobody's going to place you on this medication and just walk away. It's going to require a lot of monitoring. And remember that without this medication, there is a decline or a natural progression of worsening of systemic lupus. Meanwhile, when you're on this medication, you're more likely to become better, and even some of these side effects may not even occur anyway. If you do have, number 4, if you have new symptoms, it's important that you speak to your doctor or get an appointment so that that is quickly checked as quickly as possible. Number 5, it's important to mention that when I talked about things that can affect the prognosis, because of the chronic inflammatory state that occurs in lupus, there is a possibility that down the line, patients may develop conditions that cause accelerated atherosclerosis, resulting in things like high blood pressure, cardiovascular disorders from lipid dysfunction. So it's important that you can also check your blood pressure from time to time and also ensure that your lipid profile is checked. Number 6, mind the sun. The sun, remember, ultraviolet rays from the sun can affect production of autoantibodies and definitely cause some form of irritation of your skin. So it's important that you use sun protection factor and appropriate dressing so that you cover adequately when you are going to be exposed to the sun. If you smoke, number 7, stop smoking. Number 8, get guidance for vaccination. Avoid live vaccination, but please speak to your doctor before you take vaccinations. And then number 9, remember that this condition more likely to occur in females, and so it's important that you speak to your doctor, and pregnancy should be adequately planned. It must be at the time where the disease is adequately controlled. You've had some interaction, consultation with your doctor to check and see that the disease is adequately controlled before you plan to get pregnant, because systemic lupus can affect pregnancy and pregnancy can affect lupus. So it's important that pregnancies are planned. Number 10, healthy eating and exercise are always going to be important. But please remember, the exercise that you carry out must be tolerable exercise and nothing beyond the usual. And it's important that if you're going to engage in certain types of exercise, you speak with your doctor to determine whether that is something that you should be at all involved in. This has been a rather long video. It's possible that we're going to put it into parts, but please, you can take your time to listen again and again, and then send to somebody that you know has lupus, suspect has lupus. But please share, like, and do subscribe. Thank you, and have a good time.